Hi, everyone. Good evening and welcome back. I am Elizabeth, one of the travel nurses from CNY Fertility, and we'll just give some time for some folks to join us. But I typically come in every week or every other week on Monday evenings around this time to talk about everything being a travel client and the process of being a travel client. And so our global travel team helps to facilitate cycles for anybody traveling to our office from a distance away. So some people are just coming from a couple of hours away, whereas other people are coming from a couple of hours flight away. So no matter where you are, you can go through treatment with us here at CNY Fertility and experience a great quality of care. And our team, the travel team, is here to help with that, to make sure that everything that you need to do prior to coming into one of our clinics is done well, is done on a timely basis, and we're able to get you those instructions kind of real time. So welcome to everyone who's joining us. Again, I'm Elizabeth. I'm one of the global travel nurses, and our team, as I've been saying, is here. We exist to provide everything you need in terms of cycle help and cycle coordination up until the time that you come into one of our offices. So tonight we're going to talk all about embryo transfers, kind of what to expect, whether you do a fresh transfer or a frozen transfer, some of the different protocols that we use for our different transfer cycles. And then we'll talk about some of the add-on therapies that we offer that are very unique to CNY Fertility, but some of those add-on therapies that we offer here. So it seems like some people are excited about the topic tonight. So off we go. It looks like we've got quite a handful of people here. So we'll go ahead and get started. So an embryo transfer can either happen what we call a fresh transfer or a frozen transfer. So a fresh transfer is one where you do your egg retrieval and your embryo transfer on the same cycle. What that means is you get a period, you would do the stimulation part of the cycle. So that's where you take the majority of the injections. And then when the time is right, when the follicles are all looking to be nearing maturity, we would give you instructions for a trigger shot. And then we would schedule your procedure according to that trigger shot time. And so if you do end up doing a fresh transfer, that transfer is going to take place 3 to 5 days after your egg retrieval. And you will receive all of the transfer details and instructions in terms of medications. You will actually receive those instructions from the office team, so from our nurses in our offices. The global travel team, we plan all of the frozen cycles, and then you would get all of your instructions for the medications and the transfer from the travel team once we've determined that everything looks good to proceed with the transfer. So yes, I am going to discuss pros and cons of the add-ons, of HCG boosters, all of that stuff. I will totally get into that. Okay, so a frozen embryo transfer is just that. It's an embryo. It's a transfer of a previously frozen embryo. So it's a little bit misleading in that the embryo is not frozen when it's placed into your body. It is thawed, and then it is put back in the body. When we thaw an embryo in the lab, we're looking for certain characteristics that embryo has thawed in a healthy manner and is looking good for transfer. We have an extremely low rate of failure to thaw, or embryos that don't, quote, survive the thaw. So somebody's asking about a fresh versus frozen. We'll talk about that in just a second. But so frozen embryo transfer, we typically what we'll do is, so you either froze your embryos because you just wanted to make the process easier, and a lot of our clients who travel do choose to do a frozen embryo transfer, given that the timeline of the process is a lot easier to anticipate. So somebody was asking, when will we know if we can do a fresh transfer? So part of the process is we need to make sure that doing a fresh transfer is safe. And what do I mean by that? If you've stimulated your ovaries and we either give you a trigger shot with HCG in it, or you become pregnant, which then creates HCG in the body, that HCG serves as sort of a flare to the ovaries. And so we don't want to introduce HCG either in the form of a trigger or in the form of a pregnancy if we think that your ovaries are so overstimulated that HCG is going to flare them in a dangerous way. So OHSS, I'm sure many of you have read about it. If you've read through your travel packets, you know that is a risk of ovarian stimulation, IVF, retrieval, etc. And so we want to always protect you against the chances that you will develop moderate to severe OHSS. So to avoid that, if the estrogen levels are above, it's discretionary, it's up to the doctor, but it's usually somewhere above 3,000. Sometimes if you've had a lot of follicles retrieved, if it's above 2,500, sometimes we'll encourage you to do a frozen transfer instead. But in any case, a frozen transfer is one you either elected to freeze them all and come back, just because, like I was saying, it is a little bit easier in terms of, if your retrieval's on a Thursday, as long as you're doing well, you can go home on a Friday. So you can come in on a Wednesday evening, you could come in for Thursday's retrieval, rest the rest of the day, and go back home on Friday. And then when you come in for your transfer, you can do the same thing. You can come in the night before, have your transfer, leave the day after. Some people leave the day of the transfer, and that's up to you. Medically, there's no real reason why you can't. I'm just a big proponent of encouraging you to rest and have low stress day of transfer. And there's always some level of stress involved in traveling. So, but either way, if you can come in the night before, do the procedure the next day and leave the following day, you typically end up staying in a hotel less time in total than if you stayed for a fresh transfer. So frozen transfer, you either elected to freeze them all, or we advised you, hey, look, might not be safe to do a fresh transfer, come back for frozen. And so what happens is those embryos are safely frozen in the lab. Embryos can be frozen for an indefinite amount of time. So we do get that question from time to time. I did a retrieval and I was going to do a transfer. Something came up. Now I can't do it for a few months. Is that okay? Absolutely. Embryos can be frozen in the lab pretty much indefinitely. And so I think recently there was a news story of a birth of a baby who had been an embryo frozen for, I want to say it was somewhere in the 20 to 30 year range. So definitely can be done. But in any case, that embryo would be thawed the day of your embryo transfer and placed back in your body. But we want to make sure that your body is ready when that embryo is put back in two ways. One, we want to make sure your lining is thick enough. And then we also want to make sure that your progesterone levels, or the amount of progesterone in your body, is exactly what your embryo is expecting. So what would happen is you would give us a call with cycle day 1. You would let us know that you have started, and we would give you a date for your baselines. You guys are so kind. Thank you both. We would give you a date for your baselines. And what we're looking for at those baselines is we want to make sure that the previous endometrial lining that you built up. So if you recently did a retrieval, your embryo or your endometrial lining has thickened up. And that's what happens every month is your lining thickens up in response or in preparation for pregnancy. When the body recognizes there's no pregnancy, the estrogen and progesterone come down, and then the body is signaled to bleed off that endometrial lining. So we want to make sure that you did in fact bleed off all of that lining. And what we look for is ideally something thinner or less than 7 millimeters in thickness. So what we see is if your lining is 8 or 9 or 10 millimeters, that's an indication that your lining did not completely thin out. And so I kind of liken that to, if you are potting a plant, and if you're anything like me, I'm not very green thumb. So I've potted a plant. I did this back when coronavirus, when we were all in quarantine, sort of very strictly, and I tried to grow herbs and it just didn't happen. And so this would have been the equivalent if I had tried to grow those herbs. I struck out. I didn't do well. If I took that old soil that I failed to grow those herbs in out, I put nice fresh soil at the very bottom of the pot, and then I put all that old soil back in the pot. And then I expected those new little seeds to grow in that old soil. It's a very similar kind of idea behind getting rid of or bleeding off that thick lining, so that what's growing and what's going to be right there for the baby, for the body to sort of engulf and start the implantation process is nice, it's fresh, it's nutrient dense. Somebody is asking for how can you make sure you can do a fresh? You can't really make sure, other than if you choose to proceed with a fresh against our recommendations. I guess that would be one way to be sure. But we will always tell you here at CNY Fertility, we truly, truly believe that this is your time, it's your money, it's your body, it's your embryo. So if we tell you, listen, we don't think a fresh transfer is in your best interest, your lining's too thin, or maybe you're at risk for OHSS, I think OHSS risk is about the only time we will say, no, you cannot do a fresh transfer. But there's no really good way to sort of ensure one, just because there's so much that's left up to the body to decide. And that is, how high is the estrogen level? How thick or thin is the lining? And so there's no real surefire way to make sure that the embryo transfer can be a fresh transfer. So, okay, so you've got these surplus embryos and you call us cycle day 1. We tell you, go ahead and go for your ultrasound and your lab work on whatever day. And that's where we're looking to make sure that the lining is thinned out. If it hasn't, we'll always give you the option. We'll say, listen, it's 8 millimeters. It's kind of on the line. Do you want it to be super, super safe and make sure that everything is perfect, or do you want to just give it a try and see how it goes? Most of the time, if the lining is too thick, between 7 and 8 is usually negotiable. We often start in that range. Anything above 8, we start to get worried that it's too thick, that old lining has not shed, and it's just not going to give the best environment for the embryo. And so once we confirm that your labs look good, that your lining is thinned out, then we're going to start the process of developing the lining. So there's a couple different processes that you can use, or protocols that you can use to go into an embryo transfer. And the 3 primary ways are, you can do a natural cycle, fully natural. Most people will usually only take maybe prenatals, any supplements they take, and maybe sometimes like some LDN or some of the immune medications. And what we do is we track your natural ovulation. So we usually, typically, regardless of whether you do a natural transfer, a modified natural, or a medicated cycle, we typically are going to start whatever we're going to start. And then we're going to, and I'm going to talk about transferring 1 versus 2. I see some chatter and I'm totally going to get to that. So except for, what was I just saying? Once we determine everything looks good, that's when we're going to start the process of either the natural, the modified natural, or the medicated. Now, all of the goals are the same, which is to get that lining thick enough for transfer. The differences are that a natural cycle, we're simply monitoring your own natural development of a follicle. Once that follicle is large enough to indicate maturity, we will either, you'll be the decider of this. If you're willing to trigger, the trigger helps to determine exactly when your body would start making its own natural progesterone. So we mentioned kind of before that progesterone is a natural part of a healthy growing pregnancy. And an embryo expects there to be a very specific amount of progesterone in the body when the embryo kind of comes to the party. So if there's too much or too little, this is typically an indication to the embryo, not the right time, let's try again next time, essentially. And so a natural cycle can be a little bit tricky in that if you don't want to trigger, then we have to sort of really monitor you very, very closely to determine exactly when your LH is surging, because it is that LH surge that tells the body, okay, let's make our own progesterone. It's time to get going. And so that is, in a natural cycle and a modified natural cycle, you are going to have more monitoring visits than you do with a medicated cycle. So a medicated cycle, we're taking all the guesswork out of it. We're taking this idea that let's count on my body to do what it's supposed to do. We're taking that out of it, and we're saying, let's give you medication. that medication, which in this case is estrogen, that estrogen will thicken up the lining. It also suppresses ovulation typically, which is a good thing because then we are in total control of when the progesterone starts. And then once we have you go back to your monitoring facility, which for all types of cycles is the first lining check is usually around cycle day 10. So whether you're doing a natural cycle, a modified natural cycle, or a medicated FET, you're going to go back for the first monitoring visit sometime right around cycle day 10. If you're doing a medicated cycle and your lining is ready at that first check, you don't have to go back. That's one of the nice things, especially about being a travel patient, where we know so many of your facilities charge you guys insane amounts of money for these monitoring ultrasounds. The nice part about a medicated cycle is I would say at least 75% probably of our clients are able to do their baseline, go back for that lining check around cycle day 10 to 12, start progesterone according to our timeline, and transfer about a week later. That's the typical trajectory for a medicated cycle. With the natural and the modified natural, we're trying to watch your follicle develop, and right when it's ready, then we sort of determine the transfer kind of around that. And sometimes what happens as well with that situation is you will every now and then, it doesn't happen a ton, but every now and then the transfer sort of based on your own natural cycle needs to fall on a Sunday, and we're not here on Sunday. And so that presents a situation where we can either kind of push it and hope for the best, or we can cancel and start over. And so that's no fun. Michael says their CNY IVF baby will be 1 month old tomorrow. Happy 1 month old. Happy 1 month birthday, little baby. That is so exciting. You are so welcome. It is our absolute pleasure. Okay, so once the lining so in a medicated cycle, all we're really looking at is one, is your lining thick enough? And thick enough is anything above 7. And ideally a trilaminar pattern. I can't remember, Devin, I think it might have been you pointed out a couple of weeks ago that this painting behind me looks like a trilaminar endometrial lining. And so now I can't unsee it. So this little block down here is kind of what an endometrial lining looks like on an ultrasound, in that if it's trilaminar, there's this white sort of line. Yep, Devin, that was you. There's this sort of white line in the middle where the two sides of the uterus come together. And that lining pattern gives us an indication that the tiny little vasculature, or that little vascular network of blood vessels has started to develop into that pattern that will be the most advantageous for implantation. Somebody's asking, can the lining be too thick? Theoretically, yes, but it's very, very rare that I see a lining get too thick. We don't start worrying about too thick until you get usually above 20 or so millimeters, sometimes 22. So I would say for the most part, I rarely see people's linings get that thick. And so yes, it could theoretically, but it's not very common that it does. So to book your FET, we're looking for your estrogen level to be above 100. And then we want your progesterone level to be less than 2. But so yes, 7 is a great lining measurement. Anything between 7 and about 18 is great. Up to 18 to 20 is usually fine. Less than 7, we will rarely book that unless that is the best you can do. Anything above 7 in trilaminar is ideal. So 7 is just the minimum, but 7 in trilaminar, the research shows that is an adequate and a perfectly fine lining for transfer, anything above 7 in trilaminar. Some things that would prevent a fresh transfer are kind of as we talked about before. So if you come for retrieval, your estrogen's super high. Like I said, anything between 2,500 and 3,000 is probably negotiable. Depends on your own individual age, your AMH level, how many follicles we retrieved, etc. Anything above 3,000, we're probably going to recommend a frozen transfer. So high estrogen would prevent a fresh transfer, as would if you increase your progesterone increases during the cycle for any number of reasons. So let's say you're doing a retrieval cycle and you've grown all of these follicles and one of them sort of ovulates sort of spontaneously, and that does happen. You can just spontaneously ovulate an egg, and that follicle where the egg ovulates sort of secretes progesterone. And so if that happens ahead of schedule, again, an embryo is looking for a very specific amount of progesterone when it sort of comes to the party, whether that's a fresh transfer or a frozen transfer. That embryo is looking for a very specific amount of progesterone. So it's usually, for a blast embryo, it's around 120 hours, give or take about 3 hours. And that's why we almost always recommend that that if that estrogen if that progesterone gets too high, then we say, okay, there's going to be a mismatch between the amount the embryo is expecting and the amount that's there, and it's not going to work. So if your estrogen gets above 3,000, if your progesterone gets above 2, those are both common reasons that we might look at doing a frozen. Now, yes, there are medications that can be used to prevent the estrogen from getting too high. However, the estrogen being high itself is not necessarily the problem. The problem is what that high estrogen is a sign of. So that high estrogen is a sign of very flared ovaries. And so if you take letrozole sort of inhibits or blocks the estrogen levels in the blood. And so somebody who might, without letrozole, have an estrogen level of, let's say, 3,500, with letrozole, they might only have an estrogen level of 800 or 1,000. But they both are still kind of reflective of the same issue or the same concern, which is, if we add HCG to this picture, what is going to happen? Are we going to end up with severe OHSS? So just because we use letrozole does not mean that we can definitely do a fresh transfer. We will always do our very best to facilitate whatever type of transfer you're wanting, but we want to make sure that we do what's safe. And so that's, again, yes, a letrozole can lower that estrogen level, but it is more about what is that estrogen a sign of. And so even if the letrozole lowers the estrogen, let's say the estrogen peaks at 1,000, if there are 40 follicles, the risk is still there that the patient would develop ovarian hyperstimulation syndrome if HCG were to be introduced to the body. So very long-winded way of saying it is always, negligible. Now, Devin is saying her estrogen was 9,570. Yeah, that would not have been a case where we would ever consider a fresh transfer, ever, ever, ever. And like I kind of said earlier, we will always try to facilitate a fresh transfer as long as it's safe. But in that situation where the estrogen was 9,500, we would have instantly caused ovarian hyperstimulation syndrome. And I'm guessing you may have had a touch of it regardless, given that estrogen. So, okay. So I'm seeing a lot of questions and chatter about embryos to transfer and what number to transfer. And so what we are always here to do is to get you pregnant and help you deliver one healthy baby. One embryo is almost always considered best. The reason why it's ever considered to transfer two embryos is because we know that as we age, we are more likely to create embryos that would not survive a pregnancy, meaning that it's got some type of abnormality that it will not implant, or if it does, it will not be an ongoing pregnancy. So there is a set of guidelines developed by the American Society for Reproductive Medicine, and those guidelines are there. They're established to help prevent the situation of pregnancies with multiples, so twins, triplets, quadruplets, even higher order multiples. These pregnancies are dangerous. There are plenty of twin pregnancies that go really well, but there are also plenty of twin pregnancies that do not go well. And inherently, pregnancy in and of itself, speaking from someone who I used to be a labor and delivery nurse, is a real miracle in terms of everything that happens to the body. And so to add a multiple pregnancy to the situation certainly will increase risk. It increases your risk of pregnancy complications, delivery complications, NICU stays. The list really does go on. So our goal is always going to be to help you get pregnant, stay pregnant, and deliver one healthy baby. With that said, if you are requesting to transfer 2 embryos and you've had multiple failed transfers, well, the guidelines, we can justify making an adjustment to the guidelines if, for example, you've had multiple failed transfers. But for the most part, if you've never done a transfer, or you've done one failed fresh transfer, the guidelines are still pretty clear that your best chances of delivery of one healthy baby is with a single embryo transfer. And so it is important to note that, as I mentioned earlier, this is your time, this is your money, these are your embryos. It is, in most cases, it is your choice. However, our goal is we always have to keep you safe. And so there are some instances in which we won't do a double embryo transfer. And situations would probably include things like early or previous preterm labor or preterm birth, cervical failure or cervical insufficiency where, the cervix dilates early and you need some type of intervention. Things like preeclampsia, even just, severe gestational diabetes. There are certain instances where we're going to recommend against a against a double embryo transfer. But at the end of the day, our job is to give you all of the risks, and ultimately, typically, you are able to go against those guidelines as long as you are able to acknowledge that A, it's against medical advice, and that B, it does put you at high risk for pregnancy, labor, delivery, and neonatal complications. So the guidelines are, for the most part, if you're under 35, it's almost always going to be to transfer one. The guidelines state that between about 35 and 37, 1 to 2, and then from 37 up, then that number increases. And the reason why it increases is because we know that the chances of an embryo not being viable, those chances increase as our age increases. And so that's why the guidelines increase the number allowable to transfer as we age and as our embryos are less of a high quality. So the higher quality, and if your embryos are blastocyst versus cleavage stage, we know that blastocyst embryos have a lesser chance of miscarriage and a higher rate of implantation. So the guidelines with cleavage stage embryos are usually higher in terms of number to transfer than blast embryos. And then if you do genetic testing on the embryos, then the recommendation is always going to be one at a time. Because you have to also remember that, if anything, I'm sure if I asked by a show of hands, and we can't really do a show of hands here, but I'm sure if I asked by show of hands, how many of you watching tonight have done an embryo transfer, everything looked perfect, lining was great, labs looked perfect, everything looked perfect, and it didn't stick? And I'm guessing by show of hands that there would be a lot of hands up. And so the question is, what is the reason that embryo didn't stick? And there's a lot of reasons other than just, well, the embryo had an issue. There's other issues. So there's receptivity issues in the uterus. There are immune issues. There's a lot of different things that can contribute to failed implantation or a failed transfer. And so then you have to start weighing this idea that, well, if I'm transferring 2 and there's one thing that's not perfect. Now I've lost 2 embryos instead of just 1. And so as a general rule, the guideline or the recommendation is always let's transfer them one at a time. Everybody individually will have different, a different set of circumstances. And so you can always ask. We'll always give you our best understanding or our best recommendation. But like I said, unless it is going to be clearly unsafe for you, most of the time we will do whatever it is that you choose. Somebody is asking if I could clarify what genetic testing is. There's 2 forms of genetic testing, and this does get a little bit confusing. So it hopes that I don't go off on a tangent. The 2 types of genetic testing kind of are genetic testing that you do on yourself prior to a stimulation cycle to determine whether or not you're a carrier of any genetic disorders. So that's one type of genetic testing. Like I said, that's done before you ever stimulate, make eggs, embryos, and that type of thing. But then there's genetic testing that you can do on the embryos. It's called PGT, pre-implantation genetic testing. And this testing serves to determine if the embryo has the correct number, structure, and arrangement of chromosomes. And so in an embryo, we expect there to be 23 pairs of chromosomes. If there are more than or less than that number, then we know we have what's called aneuploidy, or an embryo that's not considered chromosomally normal. Now, there's a very healthy debate in the fertility community with very, very strong arguments on either side about the ability or the potential ability of an embryo to sort of correct after the point at which you would do the genetic testing. So if you're wanting to do genetic testing, PGT, then you're definitely going to be doing a freeze-all cycle, meaning you're going to come to one of our offices, retrieve, we're going to make embryos, we're going to grow them out to the blastocyst stage, and then at that stage, we're going to biopsy some cells from the part of the embryo that becomes the placenta, and it's called the trophectoderm. So yes, we only test blast-graded embryos. We biopsy a few of those cells out of the placental tissue, and those are the cells that are sent for testing. So the argument on the side for testing is, well, if an embryo has the wrong arrangement or number of chromosomes, it's not going to implant. The argument on the other side is, well, you've taken such a small sample of cells from such an early embryonic stage of development that the idea is that, well, there is the potential for that embryo to self-correct, for lack of a better word, as it continues to divide and grow into a baby. And so that's the basic difference between the genetic testing for the embryos and the genetic testing that you would do beforehand. We want you to decide, or we want to know right away as you start stimulation if PGT is something you want to do. Even if you think you might want to do it, it is important. There's some paperwork on our side that we have to get completed before you actually go to retrieval. So we do want to try to initiate that paperwork sooner rather than later to make sure that you understand what the costs are going to be and that type of thing. So you technically could decide, day of trigger, but as a general rule, we'd like to know now rather than later, just so we can make sure that we've got everything filled out. So, okay, so number of embryos to transfer, we kind of talked about that. It's depending on, are they tested, are they not tested? Are they day 3s or are they day 5s? And how old are you? Those are kind of all of the parameters that we discuss. I've gotten this question a couple times, so I am going to answer it. And that is, what medication do we use for the FETs? So that depends on if you're wanting to do that natural cycle I talked about, where we're just watching your egg develop, and then we're trying to time the transfer according to that. Most of our clients, just again because of monitoring costs and timeline do a medicated cycle, and that is going to include Estrace or estradiol. Though that medication is almost always included in your initial medication order, plus LDN, prednisone, baby aspirin, if it's not contraindicated for you, prenatal vitamins, and usually a Z-Pak. Those are the typical frozen transfer medications. And then, of course, if you've been prescribed any of the immune protocols, those medications are all intended to accompany the transfer. So the majority of the immune medications like Neupogen, Lovenox, Plaquenil, a lot of those medications are all started at your baseline. Why is, I've seen this question a couple times too, which is, let's see here. Sorry. Why are frozen transfers more successful? Typically because, one, we've given the body some time to rest and allow those ovaries to go back down to normal size before transfer. So if you can imagine, the ovaries are they're very small. And if we've stimulated them, we've sort of grown them into 3, 4, 5 times their normal size. That's going to create inflammation, cramping. It's going to create a situation where the ovaries are flared. Plus, in a fresh cycle, we can't always get the lining as thick as we would like. We can't always guarantee that it's going to be that triple stripe pattern we're looking for. So there's a couple of different reasons why frozen transfers are typically more successful, but the majority of them have to do with the ability to get everything exactly the way we want it prior to the embryo transfer. Any questions that have kind of trickled in here about cost? Unfortunately, I am not the right person to answer those questions. I would probably give you the wrong answer. So on the financial questions, please make sure that you direct those to our financial team. They are absolutely wonderful, and they would be able to get you all of the information on exactly what costs are involved. So yes, they are all pretty much the same medications, fresh versus frozen, with the exception of Estrace doesn't always need to be added in a fresh cycle. And sometimes we can get away with using less progesterone support for a fresh transfer, because through the process of ovulation, the body makes some of its own progesterone. But as a general rule, we are looking for, we are trying to find that balance between the two. Okay, let's answer a couple, or let's kind of go in a little bit to, so once we've determined that you're ready for transfer, and that is either you've got a mature follicle that's ready to trigger, that would be in a modified natural cycle. In a natural cycle, you've got an LH surge and you're ready to start the process of ovulation. Or in a medicated cycle, the lining is thicker than 7 millimeters and preferably trilaminar. We're going to schedule the embryo transfer according to the type of embryos you have. So if you have a day 3 embryo, you're going to need 3 full days of progesterone leading up to the transfer, versus if you have blast graded embryos. Now, this means day 5 embryos, day 6 embryos, day 7 embryos. Just because an embryo took till the 7th day to make it to the blastocyst stage does not mean it needs 7 days of progesterone. The standard is still 5 full days for a blast and 3 full days for a cleavage stage embryo. And so we would give you instructions on when to start those start your progesterone products. So if you've got a day 5 embryo and your transfer's on a Monday, you're going to start your progesterone at 11 a.m. In whatever time zone the transfer is scheduled for on a Wednesday, so that you have Wednesday, Thursday, Friday, Saturday, and Sunday. You've got 5 full days of progesterone by the time the transfer arrives, because your embryo is going to be expecting that 5 full days of progesterone. And then at that time, you would get all of your transfer information. So you would know when you needed to be here. If you were going to do some of the add-ons, and I'll talk about those in a minute, most of the add-ons need to happen the day prior to the transfer or 2 days prior to the transfer, depending on what they are. Intralipids can be done the day of transfer, but things like the washes and that type of thing are done the day before. let's see here, only normal embryos can be transferred after PGT. So that's not necessarily true, Mary. If you went through PGT and nothing came back normal, what we recommend is that you reach out to, whoever did the testing. We primarily work with Cooper Genomics for the PGT. So it would be to contact them. Part of what you pay for when you pay for PGT is you pay for genetic counseling. So we would want you to have a genetic counseling session with Cooper Genomics, with one of their genetic counselors, to determine for your specific embryos that tested abnormal, what are the implications of transferring that embryo? What are the pregnancy implications, and what are the potential implications to the baby itself? And then if you choose to proceed, we do have a consent form that basically says, you're transferring an abnormal or mosaic embryo, and that there are chances of pregnancy failure, implantation, pregnancy failure, fetal anomalies, things like that. But you are able to transfer them if that's all you have. Okay, so let's talk a little bit about some of the add-ons, and let's answer some questions. So some of the add-ons that we have to offer prior to the embryo transfer are, let's talk about first the two that can be done the same day of transfer, and then we'll kind of work back. So, one of the add-ons really isn't an add-on anymore, and that is embryo glue. So embryo glue is something that we now include for all transfers. So that's no longer something that has to be requested. I believe as of September 1st of last year of 2020, it might have been as far back as 2019, but we started including the embryo glue for everybody. So that's no longer really an add-on that you need to sort of ask for. The two other add-ons that you can do the day of the transfer are intralipids and acupuncture. So the acupuncturists here at CNY Fertility might kill me for saying this, but I don't recommend doing acupuncture if you've never done it before. The first time to do acupuncture is probably not a great time to do that is probably not the day of your transfer, unless you truly have no reservations about it whatsoever. Then you go for it. But ultimately, somebody is going to be, putting needles in your body. There is some inherent level of stress with the first time that you have that done. My opinion is that acupuncture really doesn't really hurt. It's very calming, but the first time was a little nerve-wracking because I had never done it before. And so if you've never done acupuncture before, you decide how you want, but the day of your transfer might not be a great time to try it for the first time. I recommend looking in your local area. Acupuncture done weekly or biweekly in the weeks leading up to transfer has shown a huge increase in implantation and ongoing pregnancy rates. And so, highly, highly effective treatment. And if you're not already doing acupuncture, that's a good thing to look into doing there locally prior to the transfer itself. And then the intralipids are, some of you might have them in your possession. So intralipids are a pretty popular part of many of our protocols. And the idea behind them is to suppress any natural killer cell activity in the uterus that can attack the implantation or early pregnancy process. And so intralipids are not indicated for if you have an allergy to usually nuts, soy, egg. Those are big no-nos. You're likely to have a problem with intralipids. Anybody who has any known liver disease is not a good candidate for intralipids. Also, if you're a diabetic, we definitely would want to discuss that beforehand. Any type of hepatitis where the liver has been strained, we want to, the intralipids are processed and excreted through the liver. So we just want to make sure that we don't put undue stress on the liver. But those intralipids can be done the day of or the day before or 2 days before. Many people with recurrent implantation failure or recurrent pregnancy loss are going to be doing intralipids on a weekly basis, typically starting at baseline. But intralipids are a great option, even if you can only do one dose. So oftentimes you might have a follow-up talk or a consultation and we say, we want you to do weekly intralipids. Not everybody has that option. So depending on the area in which you live, you might not be able to find an infusion center or somebody, a doctor, to infuse those intralipids. And so 1 dose is better than none, 2 is better than 1, etc. If you are allergic to intralipids, there really isn't an alternative. And so we would just look at potential other options for immune support. But there isn't really another good option to replace the intralipids. Not everybody gets intralipids. They're not required. I can tell you that I did a successful IVF cycle and didn't do intralipids. And so they're certainly not required. But if they are indicated or they're prescribed for you, there's a very good reason why. And we want to try to at least get those in day of transfer up to 2 days before transfer. Yes, if you do intralipids 48 hours before transfer, definitely beneficial. Again, 1 dose is better than none, 2 is better than 1, etc. So the other 2 add-ons, probably the most, I'd say intralipids, HCG wash, and PRP altogether are probably the 3 most common intralipids. Bree, I apologize. You've asked your question several times. I'm going to answer it now because I feel terrible that I haven't answered you yet. I just haven't found a good way to work it in. But Bree says we had a second egg retrieval last week, 3 fertilized, having them tested, and we want to do another egg retrieval. Yes, if you wanted to do a transfer of one of your embryos after your egg retrieval, you certainly could do that. We've done that before. Again, you would want to make sure that all the parameters look perfect because, with that fresh cycle, you want to make sure the lining and the labs all look appropriate. But as long as they do, yes, we have had people that go through an egg retrieval and transfer an embryo from a previous cycle while they wait for the current embryos to be tested. So yes. Are add-ons allowed if you're doing IVF only to eliminate a genetic condition? Absolutely, Bree. So unfortunately, for some people, we don't know if you're going to have a concern if until it happens. And so 100%, you are, as long as there are no medical contraindications, you can add any of those add-on therapies, intrauterine PRP, HCG wash, intralipids, embryo glue, acupuncture, any number of those things can be added, especially if you did IVF to eliminate a genetic condition, then not only did we have to get lots of good quality eggs that then had to fertilize and develop into blasts, but then we had to sort out those embryos that had the genetic condition that you were trying to avoid, leaving you with even fewer behind. And so, yes, you are more than able to add any of those add-ons that you want in order to increase your chances. So intrauterine PRP is the infusion of your own plasma from your blood into your uterus 24 to 48 hours prior to the embryo transfer. So the idea behind the PRP is that your plasma has within it platelets, stem cells, growth factors, and all kinds of good juju, so to speak, for lack of a better term, to improve the receptivity inside the uterus. So PRP, platelet-rich plasma. And what we're trying to do is what you would come in for is a blood draw. We would separate that blood, the liquids from the solids, and the liquids would be what is placed inside the uterus. And those stem cells, those growth factors, are able to go to work in nourishing the inside of the uterus to prepare it for implantation. Now, what if you notoriously have a difficult time creating a thick enough lining for a transfer? Well, an intrauterine PRP infusion can actually help with those growth factors and whatnot about a week before the lining check, can serve to thicken up the lining so that it is thick enough for transfer. So there's actually 3 different kinds of PRP. There's intra-ovarian PRP, which is typically done with an egg retrieval to improve outcomes in future egg retrievals. There's the intrauterine PRP, which is done to increase the thickness of the lining, and that's done about a week before the lining check. And then there's the PRP that's done 48 hours before. Amber, no, typically it does not create a fluid buildup. The reason why we want it to be done at least 24 hours before is so that the lining, or so that the body does have time to absorb that fluid prior to transfer. And so, yes, I'm so sorry, Shell. I don't know the answer to the cost questions, but thank you, Benjamin, for jumping in there. Please contact our financial department. I do believe that there are some costs on our website as well. We try to be as transparent as we can be. I know there's some calculators on the website in terms of the different add-ons and things that you that might apply to you. So definitely check there, and then definitely get with our financial team if the answer to your question isn't there. So PRP, once again, 24 to 48 hours before the transfer, no less than 24, because we want to have that time for the body to absorb the actual fluid, helps to improve implantation rates, lower miscarriage rates, and if it's used for lining thickness, helps to increase the thickness of the lining. And then HCG wash, and my personal opinion, because I see a couple of questions like this, do I personally recommend it? Yes. One, because there's a lot of research showing that it can help, but also because it cannot hurt. I believe in trying to seize every, like whoever was talking earlier about, well, I just did this for a genetic condition, but can I add these things on? Absolutely. You can add these things on, because they can't hurt, they can only help you. And so, adding them in is a great idea if you can. And if I had the option for an HCG wash or a PRP, I absolutely would have done both. You can do both. So we can do an HCG wash and a PRP together the day prior to, or 2 days prior to the transfer. So you can do, the only types of washes you can't really put together are things like a Neupogen wash together with an HCG wash. We don't do Neupogen washes all that often because most people who do Neupogen inject it. And so usually we recommend taking the Neupogen as an injection and then doing the HCG and the PRP together 48 hours prior with intralipids if you have them, and then coming for transfer, doing acupuncture and that type of thing. Let's see here. Embryo glue, I've seen a couple of questions about how it works. Definitely check out our website. There's some more information there. But the idea behind the embryo glue is this concept that it creates or it increases the stickiness of the embryo itself, so that there's a better chance that it will stick to the uterus, engulf, and begin that process of implantation. So embryo glue, there's nothing that you have to do. Like I said, embryo glue is something we use for everybody. And so as your embryo is thawed in the culture medium in the lab, the embryo glue is in that culture medium, thereby increasing that stickiness of the embryo so that it can implant against the wall of the uterus. You don't have to decide on your add-ons. I've seen a couple questions about this. You can let us know. Now, for the person who said they're coming in tomorrow, that might be a little tough unless you have the HCG with you. If you do, call the office first thing in the morning. We should be able to fit you in depending on the office you're coming to. But if you have HCG for an HCG wash, and you want to do that, the day before, you can really decide up till the day prior to that. And we'll always do our best to work you in if we can. Embryo glue is used in all transfers, so fresh and frozen. And then I've seen a couple questions now, which locations perform transfers? All of our locations that are full service labs do retrievals and transfers, and those are Syracuse, Albany, Buffalo, and Colorado currently are our locations that do retrievals and transfers. Currently, our Atlanta office, and our Rochester and our Rochester office, I guess, are doing monitoring for us, but not yet doing retrievals and transfers. So once again, the HCG is the HCG wash. It is the same medication that you would use for a trigger. So if you have Pregnyl or Novorel and you only trigger with half of it or a quarter of it, definitely save the rest. We can potentially use that for an HCG wash later down the line, but it is the same medication. And the idea behind the HCG wash is to help improve the intrauterine environment leading up to transfer to increase implantation and ongoing pregnancy of that embryo that we've transferred. And so definitely take a look at some of the research on that. But the HCG helps to sort of create an environment inside the uterus that's going to be prime for the embryo to be engulfed in the lining and then, continue to grow. HCG wash, you do have to bring that with you. Unfortunately, we're not a pharmacy. We're not allowed to dispense medications. So if an HCG wash, intralipids, those are things that you are wanting to do, you're going to want to bring that medication with you or have it shipped from the pharmacy directly to our office so that we have it on hand. Every now and then we might have an extra HCG, but it's not super common. So yes, if you have leftover, definitely save it. If you haven't yet triggered and you get trigger instructions and you end up with leftover HCG, just don't toss it. Mark the date you mixed it, stick it in the fridge, and then we could potentially use it for transfer itself. Okay, let's answer a couple more questions here. Before you know it, our hour is about up here, but let's go. So Anne asked, she's 37, AMH of 0.91. If you have 3 viable embryos, can you transfer all 3? Probably not. And for one, you literally are putting all your eggs in one basket, which we recommend against. But also at 37, let's say you have, let's say you have 3 poor graded embryos. In that case, you probably would meet the guidelines to transfer all 3. Usually we're able to go against the guidelines to transfer 2. If we have a very good reason, we can back up that decision. Transferring 3 is typically reserved for women in their 40s, usually 41 and older. That's when the door is going to kind of open to transfer more than 2. And that's just because we know your odds increase if we transfer more than, we transfer more than 2. I saw this question a couple of times. Amy, I don't know if it was you each time. Do I see success with low betas? 10 days post 5-day transfer, it was 68, then 112, then 221. That's not a low beta at all. Those are excellent numbers without, being able to take out my calculator. Those are great numbers. So we look for, everybody thinks that the beta should double every 48 hours. An appropriate rise is considered any beta that goes up by 66% every 48 hours. So at very first glance here, I feel like you very much did that. So those numbers look great. Try not to compare yourself to other people's betas just because it's just a different set of circumstances. I think my first beta at 10 days post-transfer was about 35. And that turned out great. So definitely try not to overanalyze that, overthink that. I would say at very first glance here, those look like fantastic numbers. So keep up the great work. Continue doing what you're doing because it looks like it is working. Let's see here. Jackie is saying, egg retrieval 2 weeks ago, all my eggs degenerated. I'm so sorry. I'm doing another egg retrieval and I'm priming with Omnitrope. Is there anything else you'd recommend so this doesn't happen again? I think Omnitrope is a great plan. You should also be taking LDN. So for any reason you stopped that and that was part of your protocol, that's a good one to continue. But Omnitrope is a very, very, very good option for your type of situation. So I don't think there's anything additional that I would recommend adding at this point. Okay, so Cole is saying progesterone was 12.9 today, day of transfer. This is a great question because there were several other ones leading up that had a very similar, kind of idea behind the question. And that is, what are we looking at in terms of transfer labs? Like once the transfer, either transfer day or midways or beta, where are we looking for embryos or for numbers to be? So if you've done some type of natural cycle, meaning you either did a fresh transfer, you did a modified natural or a natural FUT where your body ovulated in the same cycle as the pregnancy happened, in those situations, we typically look for any progesterone above 10. And usually estrogen is pretty negotiable. Whereas if you did a frozen transfer, a medicated cycle, there was no ovulation, we're looking at above 20. So in your case, 12.9 day of transfer, that additional prometrium really should do the trick. The good news is, by checking at day of transfer and by checking it at midways, we still have time to increase it and still save the pregnancy. And so that's why we do it, because there is that ability to supplement more progesterone or estrogen, whatever the case may be. So we're looking at usually as long as estrogen's above 100. Now, if you've used letrozole recently or something like that, there's going to be situations where that might not be the case for you. But usually letrozole or estrogen above 100, progesterone above 20, that's typically what we're looking for. Obviously, like I said, if you did ovulate recently, meaning you did a fresh transfer or some type of natural or modified natural transfer, then those are cases where progesterone above 10 is considered to be adequate. So, okay, I am so sorry for all of you who I did not answer your question. I know I can't get to everybody, and I appreciate those of you who are consistent and can keep asking. If anybody has ideas, suggestions of future topics, Jessica, you have a great suggestion, and I am going to be having Nurse Linda from Unboxed Mom. I'm going to be having her back on our show in the next couple of weeks for another Medication Monday, and we will absolutely, that's a great idea. We'll talk all about the different medications, what they're used for, what the potential side effects are. So tune in the next couple of weeks. She'll be joining me potentially next week or the week after. It just depends on her availability. But at Unboxed Mom or Nurse Linda, she's one of our friends here on the show, and she'll be back we'll talk all about meds. But if anyone else has specific suggestions about topics, let me know. I know that a lot of new people view every week. And so for those of you who join me every week, I don't mean to bore you, but I'm trying to include everybody. So if you have ideas for topics, suggestions, I do typically come back to these comments a couple of days later. I try to still answer questions where I can. But if you have topic suggestions, please let me know, because I don't want to bore you. I don't want to come to you with things that aren't helpful. So let me know of any specific suggestions for topics. And then if anybody and I was just going to say, if anybody has questions about their transfer, about any questions that we didn't answer in the chat that you're dying to know, send us a message through the patient portal. If you are a travel patient, you always want to make sure you direct your questions to the global travel inboxes. I know it can be tempting to send your questions to the nursing team in the individual location that you might be going to, say nursing team Syracuse or nursing team Colorado. But the travel team, up until the point when you get to our offices, we're handling everything with regards to your cycle. So definitely send a message to the travel team with any of your questions that you have. And we will be back at this time next week to continue the discussion. In the meantime, I hope everybody has a wonderful week, and I appreciate your time. I appreciate you joining me, and we will see you guys soon. Thank you.